Hi, and welcome to the Future of Dermatology podcast. I'm your host, Dr. Fara Kamangar, board certified dermatologist. We are here to talk about anything and everything dermatology related. You'll hear from me and my guests who are dermatologists, physicians, experts, scientists, residents, and medical students in the field of dermatology. We publish weekly, so if you like what you hear, hit that subscribe button and show us some love, and thank you for joining us.
Well, thank you for joining us again. I'm very excited about today's episode. We have Dr. Paradi Mirmirani live with us today. We've had her pre-recorded session posted already, and that generated so many questions that I'm so excited to have her here. The SF Derm community does not need an introduction for Dr. Mirmirani because we know her so well. She has taught us all how to treat hair. So no introductions needed, but I am going to do a quick bio before we start. So Dr. Mirmirani, who we all know so well. She completed residencies in internal medicine and dermatology and a clinical hair research fellowship at the University of California, San Francisco. She currently works for the Permanente Medical Group in Northern California, where she serves as the assistant medical director for the Regional Clinical Trials Program, as well as the regional director for hair disorders and dermatology research. In addition to being an active clinician, researcher, and teacher, she regularly presents at national and international conferences on various hair topics. And she, of course, presented at our SF Derm meeting in Half Moon Bay, and exciting that she's coming up again at our Napa conference next year. Thank you so much, Dr. Mirmirani.
Thank you for having me. It's great to be here. I love talking about hair. So this is great.
You are such an expert and you're such a resource for all of us. I feel like we're probably all emailing you multiple times a day. At the cadence that we're in, we're messaging you with questions, and you're always so gracious with your time. You send such, I don't know if I should be promoting this because you're going to start getting more emails from the community.
No, I always get the best questions. People keep me on my toes. So yes, I'm always happy to be a resource.
Yeah, absolutely. We're so lucky to have you. At the conference, at the SF Derm conference, you gave a very thorough actually talk about updates. You spoke about oral minoxidil for androgenetic alopecia, and then went into scarring alopecias, JAK inhibitors. It was such a thorough talk. A lot of questions came up around frontal fibrosing alopecia, and you had really great comments about chemical sunscreens. I feel like that all generated a lot of questions. So I was hoping today, actually, if anything, just to maybe even focus more on that. And then you also had really interesting thoughts that I realized I'm not really doing in clinic with treating FFA as well early on with even like oral minoxidil and things like that. So if it's okay with you, I would love to kind of start with that, starting with a very niche topic here. And a lot of the questions that came out were, what are your algorithms? And you responded to one of the patient questions actually with your therapeutic tier for that slide. Actually, I'll see if we can actually even post it as a link attached to this talk, because I think it's so great. But I would love to just hear your thoughts when a new FFA patient comes in, or sometimes the ones you're seeing are probably they've seen all of us and we send to you. What are your thoughts and kind of where do you start?
Yeah, thanks for that question, Farah. It's a question I get a lot from all my colleagues. I know it's at the forefront of all of our minds. I just have to start off with an anecdote. Just this morning, I saw a patient with frontal fibrosing alopecia who had been sent to me from a colleague who had tried a lot of different treatments, a lot of really good treatments. And we were in the position of saying, hey, you look great, you look better. And I graduated her from my clinic. I'm repatriating her back with her primary care dermatologist or primary dermatologist. And that was new. That was different. It's something that hasn't been the case for a very long time. When I first started in dermatology, frontal fibrosing was a rare occurrence, and now it seems like we're seeing it everywhere. And I feel like we've gotten to the point where we understand it somewhat better, that we can provide better treatments for our patients. So I'll tell you how I approach my patients and what I've started doing differently in the past few years. Frontal fibrosing alopecia, again, scarring alopecia, those hair follicles are damaged by inflammatory attacks. So we know it's an inflammatory condition. I still use anti-inflammatory medications as my standard treatment. Plaquenil, doxycycline, topical corticosteroids, sometimes low-dose intralesional corticosteroids. But then the other strategy that I'm taking, and I've become somewhat, I'll tell people I'm become somewhat militant about this, is really trying to remove any potential triggers. There's a lot of good data out there suggesting that some of the environmental triggers for frontal fibrosing, including these chemical sunscreens or other topicals, may be contributing. We don't have enough data. It's really more circumstantial, but the data is building. The evidence is building that whether it's adding fuel to the fire or whether it's triggering, I can't say for sure, but I know that if we remove these triggers, patients do better. And that's part of my, a big breakthrough for some of my patients, that I've been treating them for a long time with anti-inflammatory medications, the various sorts. But they get better, they're stable, but there's still, there's a little bit of something going on. And then you really work hard to remove those triggers, and it makes a big difference, it seems. So I treat them like I treat my really bad eczema patients. I remove anything and everything that may be a trigger, chemical anything that may penetrate the epidermis, really. So the chemical sunscreens, I have them use mineral sunscreens that are non-nano. Tinted sunscreens are fine for that. I have them use the free and clear products everywhere, not just on the scalp, face, body. People kind of respond with this. Oh, I didn't realize I was itchy until I stopped these products. I was doing a lot of patch testing, but now I do kind of a cleanse of their skincare products. And then if they're still itchy, then we'll do a patch test. As I mentioned, anti-inflammatory medications, removal of any triggers, and then hair regrowth. So in all hair disorders, you can really think about these three strategies to improve the patient's overall outlook with hair. Remove any inflammation, remove any triggers, and then improve hair growth. So we've got some really good tools now for hair regrowth. If there's any miniaturization that you see, use minoxidil, topical or oral. For frontal fibrosing alopecia in particular, I like dutasteride rather than finasteride. And the reason for that is that we think that the pathophysiology of frontal fibrosing alopecia, scarring alopecias may involve the sebaceous gland, and dutasteride targets the sebaceous gland and the hair follicle. There's more 5-alpha reductase type 1 on the sebaceous gland. So that's the theory as to why. And there was a big Spanish study that looked at response in frontal fibrosing alopecia to dutasteride versus finasteride. It works better. And I think that's probably why. So that's a general regimen. I've even had a couple patients I've seen with frontal fibrosing alopecia, first diagnosis, do a biopsy at the first visit. I tell them to get rid of all their fragrance products. And I had one patient whose inflammation had already gotten better by the time I got the biopsy results back and seen her in follow-up without any other treatment. So that's incredible. Those three things that you can do will really make a difference.
That's really incredible. And I think definitely for me, I see a lot of hair, but in no way a hair expert. So I think I probably do the thing that probably the average dermatologist is doing.
We're all hair experts.
Yeah. At this point, we see so much of it, right? And one of the main things we just kind of always think is anti-inflammatory. So when you kind of talked about those other two pillars, I think that was definitely a paradigm shift. And that's probably why you're able to send patients back to the derms of the community now, is because you've educated us all so well. So anyone is within a 30 to 50 mile radius of you probably is picking up so much of these
people
tidbits.
My colleagues do great work.
It's really a major paradigm shift with especially the patch testing. I'd love to kind of hear more what your experience there was. Because it's always it just depends on the cohort you send. If you send two or three people, they come back with some positives. You're like, this works. If you send 2 or 3, nothing comes up. You're like, I'm going to stop sending.
I'm never doing it.
I'm never doing this again. What was your experience up front? Like, were people coming back with actual positives, or is it more just like they're not necessarily? It's more like irritant dermatitis, where it's not necessarily for true allergy, but they're just
more. Yeah, I think they fall more into the irritant dermatitis, and sometimes it's obvious if they have a fragrance. Sometimes it's not so obvious. And if you send the not so obvious patients to patch testing, you come back with a negative. So I did get a slew of negatives. And then I went to the strategy of, okay, let's do elimination first and go from there. And then I have the patients who will ask me, well, I really like such and such product. Can I use it? And they'll do a use test on that one. So that's been my approach. But yeah, the more we dig, the more it seems that those environmental products do play a role. Yeah.
No, which is great. And then the hair growth is another, I think, paradigm shift. I mean, I think a lot of us with scarring alopecia will do the anti-inflammatory. We might say, okay, do some topical minoxidil too, because why not? That's like an easy thing. Everybody just do that.
Right.
But then just changing it to like aggressively starting to, do oral minoxidil, add the finasteride or dutasteride. I think that's probably something we're not all doing for scarring alopecia. Do you do that pretty much upfront? Like you're starting the anti-inflammatory, you add one of those agents as well?
Yeah, so that's a good question. I try not to do too much polypharmacy just because you run into trouble with that. So it's a shared decision making with the patient. You have those patients who are like, doc, give me everything, give me all you got. So, you pick things. And I tend not to use topical minoxidil on a very inflamed scalp. Okay. So I will try to cool them off typically with the anti-inflammatory, and then next, in 2 to 3 months, I see them back and add the next thing and the next thing. So it's usually a tiered approach. Yeah. One more thing I should add that has been exciting. There's new data out there, topical JAK inhibitors for scarring alopecias. There's new data that suggests it may be another good anti-inflammatory option for our patients. And it's nice to have those options, those, more tools in the toolkit for patients who
and
have
thank you for bringing that up, actually, because I was going to ask you a question I forgot, and I'm so glad you brought this up. I was at a meeting recently, and someone really brought up that a little bit of a tangent now, but for alopecia areata, they said, don't use the topical JAK inhibitors. It's going to do nothing. And I was like, I need to go back and ask Paradi. So yeah. What? So you
it's
think
true? Yeah.
Really?
So
okay.
we can take the tangent. We'll go on the JAK tangent for a minute. But alopecia areata, it really seems like you need the higher doses, higher strengths for the scalp in particular for it to be effective. Because way back when we were using tofacitinib, 5 milligrams BID, if it didn't work, we'd go up to 10 milligrams BID. Which we're not doing anymore because of side effect concerns. But there were definitely people who needed that higher dose. So you can imagine trying to get away with topical doesn't really do it. The few times that I will use topicals in children, sometimes I'll use it for facial hair loss. I'll use it. So in certain situations with thin skin, you may be able to get away with it. Or if you're stacking your treatments for alopecia areata and you want to stack that in, it may be worth doing.
It makes sense. But then for the scarring alopecias, like frontal fibrosing alopecia, there's some literature.
There seems to be good evidence.
It might be still doing something.
Exactly. Yeah.
And what do you think like that, and we probably don't necessarily have comparative trials, but like that versus like your topical calcineurin inhibitor or even like a topical steroid? And I'm just thinking about sometimes access is an issue with the topical JAK inhibitors. Like where do you kind of
I don't think I've had enough time to play with it to be able to answer that question for you. And I definitely have the access issue and getting it compounded or using the off-label, getting approval for the off-label is tough. So, I think it will no more
as good a time. So by June, we'll ask you again. By June in Napa. And my other questions were actually about just your anti-inflammatory ladder. Where do you? I think most of us just do the ILK initially and going to start with that. Is that kind of what you're doing as well, or are you adding more of like maybe like doxy or Plaquenil earlier on? Love to kind of see your timeline of when to set it up.
I do tend to add in an oral medication, pretty low threshold for adding in an oral medication. But that's still sometimes it depends on the patient and shared decision making. There are some patients, again, who really want to be aggressive. I'm terrified of losing a single extra hair, whereas others are more questioning about potential side effects and may not want to go to the oral. But Plaquenil and doxycycline in my mind are very low risk profile, and I'm very comfortable using those. So if they have any evidence of inflammation and, ILK along with Plaquenil or doxycycline, I will usually start there. Yeah.
Like pretty early on. And then how long do you wait before kind of bringing the bigger guns, like the Cellcept and
I really haven't had to move to those. I've really had a lot of success with going to dutasteride. Dutasteride is my favorite. So I usually start off with a doxycycline or Plaquenil and then add in dutasteride, or sometimes I'll start off with single agent dutasteride and topical corticosteroids, intralesional. So I have that anti-inflammatory, but I move quickly to the dutasteride removal of triggers. And then, I follow up with them every 2 to 3 months. And I know the question comes up, well, how do you know that they're quiet? How do you know that you've reached that success? I do a lot of photos, dermoscopy, that perifollicular scaling, perifollicular erythema, progression of hair loss. Those are all things that I monitor for. And symptoms, itch. You don't always have that in frontal fibrosing, but if you do, you can follow it. And then once I've gotten to the point where there is no itch, no symptoms, where there's no further inflammation on the scalp, no perifollicular scalar erythema, then I keep them on that regimen usually for another 6 to 9 months.
Okay.
And then slowly pair them off. Yeah. So I don't stop right away when
you want to make sure it's like really, really quiet before
exactly.
stopping.
Yeah.
How do you do with the doxycycline? Will you keep them on for that length of time?
I do.
Or do you tend to, because like in the acne world, we're like 4 to 6 weeks and a little bit longer and that's it. But for this, and do you pair them with?
I will. Yeah. Sometimes I'll stack doxycycline and Plaquenil on someone who's really tough to control. And that's more for lichen planopilaris. Again, I think frontal fibrosing gotten a little bit more success once I've added on the dutasteride and removed the triggers. Then I don't need to keep the anti-inflammatory on for so long. Yeah.
Are you doing any of the like pioglitazone much anymore?
Yes.
Still a good amount? Yeah.
Yes. So we still do use pioglitazone. We do have good data to suggest that in some patients, not everyone, PPAR gamma is a trigger. In the sebaceous gland, the PPAR gamma is downregulated. So the pioglitazone can upregulate the PPAR gamma. And it's non-immunosuppressive. So it's a good option for people with scarring alopecia of any sort, really. The only downside is some patients will have fluid retention, like swelling. And you usually know that early on. Some people will mitigate that with spironolactone. But again, it's a good option during the pandemic when we couldn't get Plaquenil and we didn't want to immunosuppress patients. Yeah, there were a lot of my patients who are going on pioglitazone.
That. Yeah. And when do you kind of bring that into the picture, or do you kind of just try it on everyone, and then the ones who are not responding just basically take it away?
I usually end up starting off with the doxycycline Plaquenil. Or if there's a reason why they can't be on those, they're photosensitivity, or there's an issue with the Plaquenil, then I'll go to pioglitazone. Or people who have been on all of those things and not gotten better, what do I turn to next? It's often pioglitazone before I go to more the heavier anti-inflammatory medications like Cellcept.
Yeah, that's so helpful for all of us, because these things come up in clinic and you're like,
where do I go?
When do I go to this? And I think I've maybe even tried only 2 people on pioglitazone. I need to bring it back more. I think the difficulty is knowing how long to keep them on there. Yeah. And when do you have them come back? Because sometimes they'll be back in 3 months and they're like, I'm not seeing anything. And then you're like, let's do something else.
I know.
Are you a little bit more patient with it?
That's usually a good rhythm for patients to be on a 2 to 3 month follow-up until you get them calmed down. And pioglitazone is one of those where you really know pretty quickly, actually.
You do. Okay. Yeah. So you would know by the 2 to 3 months.
You would know by the 2 to 3 months. And dose escalation doesn't seem to get people better who are non-responders. So they fall into 3 categories. They're non-responder, they're kind of stable, or, gangbuster responder.
That's great.
You can usually tell where they are after the first month. And if they're a responder, that's wonderful. If they're a non-responder, then
would you even have them come back a little sooner, like 6 weeks or 8 weeks once you're starting?
Sometimes I'll do a quick phone call with them to see how they're doing. Yeah.
So that's great. Maybe I just haven't had a slam dunk case, because it sounds like when you get one, you
get one, it's really miraculous. Yeah.
So when you're confused, they're confused. It's probably a good thing to just switch off. That sounds like the right move there.
Yeah.
That's fantastic. And then as far as starting like an oral minoxidil, are you still looking? I know you meant, and then another pro we picked up. We said use your dermatoscope, right? Like use dermoscopy. Look for miniaturization. If you have a patient that has had FFA or scarring alopecia for some time, they're seeing you after a while, and you're not sure if you're seeing much, would you still kind of go for the minoxidil and those routes just to try it? Or are you really just only kind of basing it based on your clinical exam, like what patients to pick to put the pro growth into treatments?
I haven't had too many people complain when they go on minoxidil for any type of hair loss. There's always a little room for I call it the fertilizer of hair. Yeah. There's always room for a little fertilizing. Most people really like the benefit they see. And most people have some miniaturization that you can work on, and any little bit of improvement that you can add in, even someone who has significant scarring, it can still be helpful.
So you would have a low threshold for trying, because why not? It'll probably help.
Yes. Well, now these days people are coming to me saying, I read in a forum, my friend told me, I hear.
Absolutely.
It's funny because some of them are expecting some pushback. I'm like, okay.
You're like, here we go. I know it works. You can have it. Actually, I'll go on a minoxidil tangent then too, just for a minute.
Yeah.
So I was also in a different meeting where someone kind of mentioned age 70 and above being like a very clear contraindication. Do you follow that? Do you have, if someone, let's say, is a very healthy 72-year-old coming in, or do you kind of in your mind have strict cutoffs of
I don't have strict cutoffs for age for minoxidil. We actually, our consensus group paper should be coming out in November.
Oh, amazing. Okay. We'll put a link to that too.
Yeah. When it comes out. But we ask a large number of folks whether they had restrictions based on age, gender, and with age, yes. So adolescents potentially starting at a lower dose, but not so much on the upper age limit, and not so much in gender, except for women having the excess facial hair. So in women, you may want to start at a lower dose and see what their response is. And if they're having excess facial hair, then you kind of stay on the lower dose.
And that would be like 1.25 or like 2.5. The 1.25.
Yes. So just half the tablet. And we worked with a cardiologist who also really, I think, was very reassuring in terms of the side effect profile and concerns that the cardiologists have with that dose is really minimal. Yeah.
That'll be really helpful to have that consensus paper, because I think there's a lot of these unanswered questions and gaps.
Right.
And then for women, are you going much above 2.5? I know the men you mentioned you go up to even 5.
Right. Yeah. So for men, we usually start at 2.5 and go up to 5. I don't really feel like you need to go above that.
Much higher. Yeah.
And then for women, 1.25 and then go to 2.5.
2.5, not much above that.
Right.
So that's that'll be really helpful. We'll be waiting for that consensus paper to come out. So fantastic. This has been so helpful, Dr. Mirmirani. And then we also, since it's the Future of Dermatology podcast, we always at the end ask what you're excited about for the future. Are there any really exciting things coming down the pipeline for the rest of the year and the near future that you see?
I was thinking about this. Yeah. I was doing a little bit of reflection, and it's not so much future, but it's here and now. But it's just been very exciting in my career. I started off when I was a resident. I was helping with patient enrollment for the National Alopecia Areata Foundation registry that was NIH funded to be able to gather more information on alopecia areata patients. And now, fast forward 20 years later, we've got three FDA approved medications for alopecia areata. And we were involved in the clinical trials as well. So it's just been an incredible ride to see that trajectory from we're just enrolling patients, we're trying to learn more, to a point where we've got clinical trials and now FDA-approved JAK inhibitors for treatment of alopecia areata. So that's really where my major excitement has been. And as we go forward, I think we'll learn a lot more in that space. Who will respond to JAK inhibitors? Who may not? Will we have testing available to figure out which JAK inhibitor people may be more responsive to? So those are the questions that I'm looking forward to answering in the future.
That's fascinating. It's true. There's the hair world has really exploded.
It's been wild. Yeah.
There are so many amazing treatments. There have been like these
Right.
certain dermatology conditions where there just really wasn't a whole lot for the longest time. And then now these really interesting mechanisms are coming out.
Yeah, it's been very exciting. Yeah.
It was just so great. And then it's also then sometimes hard to keep up with. So we're so lucky to have you to keep us up to date with all the little things that are happening. So that's great. Well, thank you so much, Dr. Mirmirani.
Thank you. Thanks for having me.
So great having you.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.